is called to order, and we will rise please for the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Christine, would you take roll call, please?
Director Danielson.
Present.
Director Wallace.
Present.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Eapen.
Present.
Kimberly, we're going to go into the education session. Would you introduce our speaker for the night?
Yes, it's my pleasure to introduce to you Dr. Vandana Sharma, and she's going to be talking about medication safety. And why don't I give a little bit of an overview of Dr. Sharma. Dr. Vandana Sharma completed her undergraduate and graduate education with an MD, PhD from the University of Chicago and completed her residency and oncology fellowship from Stanford University. She is board certified in oncology, internal medicine, and hospice and palliative care. She joined the Washington Hospital medical staff in 2004. She is the medical director of the oncology program at Washington Hospital and the medical director of the Washington Hospital Cancer Genetics Clinic. She chairs or co-chairs several committees, including the Medication Analysis Committee, Cancer Committee, and the Breast Health Task Force. She received the Empowerment Award from the HERS Foundation and the American Society of Clinical Oncology Young Investigator Award. It's my pleasure to introduce you to Dr. Vandana Sharma.
Hello, everybody. Hello. So thank you for giving me the opportunity to come and talk to you and share some of our data regarding medication safety here at Washington Hospital. So this is just a brief report outline, and I'm going to touch on 4 topics mainly. One is in terms of our overall medication safety efforts, and specifically with the effects of the electronic medical record implementation, or the EHR or EPIC, on the medication error rate within the hospital. I'll share some specific examples with you about some specific errors that we encountered and how we put measures in place to ensure the safe delivery of those medications. I will also be talking to you about the smart pumps. You've heard about these before. These are these Alaris pumps that we use, the IV infusion pumps. If you think about the old days of how a nurse used to give a patient an intravenous medication, it would just drip by gravity. Then we moved to pumps, which would give the medication at a specific rate. And now we have smart pumps, which actually know the medication that's being given. They know the patient that the medication is being given to. And there are certain safety features that allow that all to work together as a whole. And then we have an intranet link which allows us to share all of this information easily with the staff as well as the physicians within the hospital. So when we looked at our medication outcomes pre and post EHR implementation, we were pleased to realize and pleased to see that the medication error rates reduced significantly before implementation and after implementation of the EHR. And this was significant as measured by the student's t-test. The error rate, the reduction in error rate trending continued for a year after the implementation of the EMR, and we also saw that observational study that we've been participating in, which is called CalNOC, which is basically a study where staff are trained on how to observe their colleagues on the administration of medications. And in terms of looking at that CalNOC data, we were also pleased to see significantly that distractions and interruptions were significantly reduced before and after implementation of the EHR and the addition of dedicated medication safety rules. So to actually look at the data, so this is when the EHR went live. So that was on July 1st, 2013, a day that many of us remember fondly. So prior to the implementation of the EHR in the prior 12 months, if you looked at the mean medication error rate normalized to the number of inpatient days, it was about 10 episodes or 10 incidences of medication error. And after implementation of the EHR, in the 12 months subsequent to that, the rate dropped down to about 6 which was significant with a p-value of 0.001. This was a sustained reduction. So first 6 months, so it wasn't like it just happened right away and then it went back up. It was actually sustained for the first 6 months and then to the remaining 6 months. And again, looking at the trend on a monthly basis, again, here was the implementation, and then there was a significant reduction that was sustained throughout time. We have data up to June 2014. Looking at the medication error trending by month, there's been a consistent trending downward post EHR. When we look at the types of error, so one of the things we looked at when we looked at this data on a sort of a deep dive, we recognized that there were types of errors that essentially went away with the EHR. So for example, prescription order communication, because now the physicians were entering the prescriptions and entering the orders directly into the EHR. They were being picked up by pharmacy right away, acted on right away. There wasn't any issue of unclear writing, so any confusion from when a medication needed to be given because of handwriting and because of poor communication. So prior to implementation of the EHR, the mean medication error rates related to prescription orders was 4.2, dropping down to 1.3. And again, significant. In terms of medication administration, again, we saw a statistically significant reduction in the number of errors pre and post implementation of the EHR. We implemented barcode scanning. So prior to this, a nurse would actually have to look at the medication, read the patient's name, look at the patient's ID band, make sure it was the right patient, right date of birth. And now with the implementation of the EHR and barcode scanning, each patient has a unique identifier barcode. Each medication has a unique identifier barcode. The medications are all in the EHR. A nurse scans the medication, they scan the patient, and this helps ensure that the right patient is getting the right medication. In terms of measuring distractions, in terms of the workflow, so concern was raised that would the EHR increase or alter the workflow for the staff, increasing the number of errors. And in fact, what we found was the reverse, that once the EHR was implemented, we actually found that there was a decrease in the number of distractions and interruptions for the nurses, and this came directly from the CalNOC observational data. So prior to the implementation of the EHR, approximately 1/3 of the doses, there was an interruption on these measured doses. However, after the implementation of the EHR, this dropped down to about 19%. A pretty significant reduction that we see. When we look at the CalNOC data throughout the state for that same period, there was a reduction, but it was only about a 2% reduction versus what we saw here at Washington Hospital after the implementation of the EHR. So in terms of measuring the impact of distraction reduction, there are many contributing factors that can lead to medication errors because of the distractions. The nurses are exposed to a multitude of interruptions, and their ability to focus and have a working memory during critical times can be affected. So by having medication rooms, so the nurses were now having a specific room that they could go into when they were pulling the medications. It was a closed environment, a quiet environment, thus minimizing distractions. And by having the EHR right there, even at the patient's bedside, they had a clearer understanding of what medication needed to be delivered, and the workflow that followed was one that actually led to fewer distractions. Again, there was reduced time spent searching for missing charts. Nurses were no longer walking around with the medication administration record. It could be accessed from the medication room, from the nursing station, from the patient's room. The EHR actually will put up best practice advisory. So if something if somebody's trying to give someone the wrong dose of the medication or give a medication too soon, for example, a pop-up will come up from the EHR that will give a warning that will say you're trying to do something that is not indicated. So these best practice advisory alerts have actually helped reduce the medication error rate. And also sort of facilitating communication. So now rather than relying on faxes, so in the pre-EHR day, what would happen, a physician would write an order in the chart, a nurse would have to physically remove that order and fax it to the pharmacy. The pharmacist would have to remove it from that fax and then act on that order. Now, with the EHR, a physician can enter in an order, and that's immediately sent to pharmacy. One of the sources of errors prior to the EHR, for example, was something as simple as a fax machine on one of the nursing units, which was broken. And it took a while to actually realize that that was the source of the error. The fax machine was only faxing half of the page of the orders. And once we discovered that, that was obviously taken care of. But by having the EHR, we removed that step of faxing. It became a direct line of communication from the physician to the pharmacy for the medication to the nurse. So in terms of what we've been trying to do to minimize medication error and improve medication safety for our patients, we look at basically 4 principles. So when there is a process that's risky or an error that's occurred, we look at it in depth and try to figure out how can we force a function. So how can we create a structure and a function in the whole process that basically eliminates this error. So for example, we realized early on there's a medication called heparin, which is a blood thinner, and there's pull-down menus. Anybody who's worked with anything electronic knows the pull-down menu where you have a choice and there's maybe 5 or 10 choices. And the default choice for this medication initially was set as intravenous. And what we did was very quickly, we set that default route to the safest route, which was subcutaneous. So the first route that a physician encounters when given the medication is the safest route to deliver that medication. And then the physician has to consciously make an effort and thought process to select a route other than that. So by forcing that function, by making sure that the default route is the safest route, we were able to eliminate a whole class of errors. Automation. So again, safety features were built into the nursing handoff process that they would have to then go through the EMR that would give them the best practice. So this is how you sign out a patient. This is what has to happen in terms of documenting IV line tracing, best practice alerts that we talked about. Standardization, making sure that all processes were being done equally. So prior to the EHR implementation, one nursing unit may be doing something one way, another nursing unit may be doing something another way. This allowed us to roll out best practices very quickly throughout the institution. And then finally, education. Whenever there would be an error, the default thing would be, well, we just need to educate everybody. We just need to make them smarter. And what we know is that that's very important, but it's actually the low-hanging fruit on the process. The way to make the system the safest is to start up top and forcing a function that will promote medication safety. So just to give you an example of some of the cases, for example, there was a patient who received a medication in the emergency room, and the doctor wanted that medication continued, and this is a medication that should have been given 12 hours later. So the first dose was given in the emergency room, 12 hours later, the second dose should have been given. And in this case, due to the fact that the patient moved from the emergency room into an inpatient setting, the timing got off. So they got that medication sooner than they should have. No harm came to the patient, but when we saw this error, what we did was we created a whole set of medications where they must be given 12 hours apart. There's no way the medication can be given any sooner than 12 hours because of how it's been built into the EHR. So it allowed us to set the timing for certain high-risk medications to prevent overdoses of those medications. Because once that medication was given in the emergency room, it would be impossible to give another dose, regardless of where they were in the hospital, before 12 hours went by. So this is an example of the forcing function. Because certainly we could educate people and say, you know, learn about this and do it in a certain process, but by forcing the function, we make sure that this error doesn't happen again. In terms of setting up clear instructions, we were able to create workflows where a physician could order a medication and then be sure that the nurses understood the process in which to time the medication so that it was given in the appropriate place. So there's some medications that need to be given right before surgery or right after surgery, and the EHR allows us to make those transitions. So this is what I was talking about in terms of best practices, in terms of tracing the line. And again, we built in flow sheet documentation for the nurses, which basically require them to check off that at their change of shift, when they've taken over and they've assessed the patient, they've done all the line tracing to make sure that the right medication is getting in via the right route. So when I was talking about the smart pumps, so what the smart pumps do is that they have a library. So there's a library of all of the drugs that we have on our formulary, as well as how those drugs should be administered in terms of the rate that they should be given at and the total number of doses. So one place that's near to my heart, for example, is chemotherapy. So chemotherapy, if too much chemotherapy is given, it can be toxic. If not enough chemotherapy is given, it's not effective. So guardrails are exactly that. They set the upper and the lower parameter, or the higher, the maximum and minimum dose that a particular medication should be given. And it prevents either overdosing of medication or even underdosing of medication. And our compliance with the guardrails in our library is very high. You can see it's always been up in the 95% range. Compared to even the top 25% of hospitals who are using this, who are still in the 80 to 90% range. So we have great technology, and we're actually using it to its maximum ability to ensure patient safety. So again, just talking about the specific processes within the smart pumps that we're actually using to make sure is there's a team that's just dedicated to analyzing the smart pumps and the data that's being generated from the smart pumps. Alarms and alerts. So first I kind of talked about how these alarms and alerts were good things. They help prevent errors because an alarm goes up and somebody stops and says, well, maybe I should not do this. There's also an element of alarm fatigue. So if there's too many alarms that go up that aren't really important, then people can bypass important alarms. So if 8 out of the 10 alarms that you get on a given day are really not high-level alarms, people can get in a habit of just bypassing all the alarms. So what we're doing now effectively is actually trying to decrease the number of alarms which are not very important and reducing them from a rate of 3.37% down to 2.85%, and really focus on the high-risk alerts to prevent alarm fatigue. And then putting in guardrails that are effective and that are reasonable. So, for example, if there's a drug that's constantly being overridden in the guardrail library, we look at that and we ask, why is that being overridden? And then obviously back to education. So these are some flyers that we've put out to help educate the staff. And in addition, I mean, the goal of all of this is to help make our patients safer, help minimize errors, and improve the safe delivery of medications. But it does come down to cost savings. And we can analyze and get an estimate of cost avoidance by severe harm incidents over the last several years since we've implemented the Alera smart pumps as well as the EHR. And there's been a significant cost savings every year in terms of what harm could have happened and what we have avoided. And then finally, we have our intranet link, which allows the dissemination of this information to the staff here at the hospital. Thank you.
Very valuable information. Sounds like it's very effective. The other board members have a comment?
I have a question for Dr. Sharma. With the introduction of new technology, you solve old problems, but you also introduce new problems. Were there failure modes or medication error modalities that you discovered as a result of the EHR and the smartphone?
There are always new problems that any technology brings. And one of the positive things I would say about the EHR is that we now have a more robust system of capturing those errors so that we can then go on and fix them. So, and what it allows is a very rapid process. So for example, sometimes we would identify errors that were perhaps, I don't want to use the word created, but that were maybe facilitated by the technology, but then we were actually able to fix them very rapidly because of the technology. So that route example is a very easy one. We discovered that this error occurred, and we were able to, within days, make that change, whereas prior to the technology, it would have taken, weeks to months.
Thank you.
Dr. Eben?
Yeah, I'm sorry on that. Yeah, great presentation. One of the things that I was kind of curious was, a lot of healthcare institutions around the same time have gone into EHR, and are they all seeing this benefits? Or have there been reports? Studies published?
I haven't seen any published data. We're gathering data, and we're going to continue gathering data. And one of the goals of our committee is to try to publish this. And that's why we're looking at things in a very robust statistical manner.
Thank you.
Thanks.
We will now consider approval of the minutes for February 11th, 23rd, and 25th. If I can have a motion, please.
So moved.
Do we have a second? We have a motion and a second. All in favor?
Aye.
Oh, pardon me. Christine, would you take the roll, please?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eben?
Aye.
Thank you. Motion passes. Communications. Do we have any written or oral communication notices?
No oral communications.
Okay, thank you. Please note for the record. Written communications, Dr. Lunny.
I have the medical staff credentialing action items from February. We have 2 new appointments, Dr. Mark Lang, internal medicine hospitalist, and Dr. Christina Sheridan, pediatric cardiologist. For reappointments, we have Dr. Kranti Achanta, surgery, Dr. Stephen Anderson, ophthalmology, Dr. Joseph Andreessen, anesthesiology, Dr. Zhuao Chen, internal medicine, Dr. Lawrence Elner, podiatry, Dr. Paul Gaynor, anesthesiology, Dr. Ali Habibi, anesthesiology, Dr. Sammy Hung, pulmonary medicine, Dr. Rabin Ketrapal, internal medicine, Dr. Prasad Kilaru, plastic surgery, Dr. Jeffrey Kishiyama, internal medicine, Dr. Michael Lamb, anesthesiology, Dr. David Larson, radiation oncology, Dr. David Laver, podiatry, Dr. Edwin Lee, anesthesiology, Dr. David Lewis, anesthesiology, Dr. Jin Lin, internal medicine, Dr. Jennifer Louie, pediatrics, Dr. Kenneth Lowe, ophthalmology, Dr. Ethan Nichols, anesthesiology, Dr. Geeta Singh, internal medicine, Dr. Brian Smith, anesthesiology, Dr. Robert Spears, anesthesiology, Dr. Yan Sung, intensive critical care medicine, Dr. Samir Vora, intensive critical care medicine, Dr. Norman Watt, oral surgery, Dr. Vanessa Wilson, internal medicine, and Dr. Byron Wilson, hematology oncology. We have 2 physicians who have completed proctorship and advancement in the staff category. Dr. Murjala Kumar, gastroenterology, going from provisional to active, and Stephen Prado, cardiac perfusionist, going from provisional to active allied health. We have 3 physicians who have completed their proctorship prior to advancement in staff category. Carla Reeves, certified nurse midwife. Randeep Tiara, emergency medicine physician. And Sean Wong, ENT surgery. And we have several physicians with new privilege requests. Dr. Stacy Berry, OBGYN. Dr. Siobhan Calhoun, OBGYN. Dr. Jing Dai, OBGYN. Dr. Craig Johnson, OBGYN. Dr. Sudipti Prasad, OBGYN. And Dr. Padmaja Sharma, OBGYN, all requesting privileges for newborn circumcision. And Dr. Jeff Lin from OBGYN requesting privileges for Mediport surgery. And finally, we have several resignations. We have Dr. Gloria Carrion, Dr. Stephen Friedkin, Dr. Ruchi Gupta, Dr. Amir Jamali, Dr. Gerald Mint, Keith Fliger, perfusionist, Dr. Allison Robbins, and Carrie Robertson, PA, all resigning.
Thank you. We have a motion for
So moved.
approval. Thank you. Second.
Second.
Christine?
Dr. Danielson?
Aye.
Dr. Wallace?
Aye.
Dr. Stewart?
Aye.
Dr. Nicholson?
Aye.
Dr. Eaton?
Motion passes. Thank you. Dr. Lennon, we're back to you with the, pardon, did I jump? Service League, I'm sorry.
Hi.
Good evening.
Good
Hi, Debbie.
evening, everyone. I'm very happy to be here. This is my first time as the official president, so what I wanted to do is kind of give you a heads up on the report from Gail, our outgoing president. Basically, we had our treasurer resign as of mid-April. She's accepted a full-time position, a part-time position, Donna Lim, and we are in the process of training Sydney Margolis, and we're looking forward. I think she's going to be an excellent addition, but Donna did a great job, so kudos to Donna. The other thing is, between February 16th and 19th, I attended a conference down at the Hyatt Regency Indian Wells Resort and Spa for COD. And it basically is a conference that we attend once a year, and we partner with other hospital administrative, paid, as well as volunteers, and we take lots of seminars and a lot of conferences and open sessions and roundtables and do a lot of brainstorming. And it was great, very tiring, but very good. And I'm hoping that this next year it's going to be in Monterey and that more of the board will be able to attend. As well, plans for our 60th anniversary are underway, and on Wednesday, March the 4th, the committee got together to discuss the plans for this, and we're looking forward to it. The gala will be held on October the 13th, and it's going to be in the Grand White Tent between the hours of 11 and 2, so we want all our volunteers to know this, and our adult volunteers, so we hope everybody will be able to make it. And a sit-down catered lunch will be served. And there's going to be entertainment, some gifts. We're going to have a drawing for a beautiful quilt that Betty Jacobs has donated. And it's just gorgeous. And we know how well and beautiful that the quilts that Nancy does as well. So that's what's been going on. As well as I thought I would like to share with you what the volunteers have done for you. This last year. How many hours the volunteers have given of themselves? 41,069 hours was donated to the hospital last year in volunteer hours. And for the whole 60 years at this point, we've donated 1,985 hours, 487. That's a lot of hours. It's a lot of manpower and a lot of love to give to you guys. And, I just want the volunteers to know how important they are. They make such a difference to us each and every day. And to this hospital, it makes such a difference. And the support of the board here, it means a lot to the volunteers. I know it means a lot to me, and I want to just say thank you.
Well, I think the thank you goes right back to the Service League members for all of the tremendous number of hours. 1 million hours plus is
Yeah.
a phenomenal
Yeah, we're
amount
just
of
shy
time.
of 2 million. Just shy. We're hoping we could do that by
This
the
year?
celebrate, yeah.
This year?
This year. We're hoping
right.
that we can do that by the time our 60th anniversary celebration is in
That
October.
would
be
a
really
ni-
great.
That would be a nice accomplishment.
Yeah, it would.
So congratulations.
Thank you.
Welcome to your year of presidency, and you did a great job tonight. Thank you.
Thank you. I'm very excited and looking forward to it, and want to make it the best volunteer organization that we can. So,
Well, we
thanks
have
for your support.
We have the best.
Thanks. We
Just
do. That we do.
Keep it right there. Okay.
Thanks.
Anyone else wish to say anything? No? Okay. Thank you very much.
Thank you.
Okay. Dr. Lunny, now,
The current composition of our medical staff is 548 members, 338 active members, 94 provisional, 64 ambulatory, 27 courtesy, 19 allied health, 3 consulting, and 3 administrative. And we currently have 4 applications pending, 6 that are, or 8 that are in the pre-application stage, and 6 with formal applications.
in Nancy's absence, Kimberly Hartz is taking her place tonight, and would you give us the hospital calendar report?
Yes, so I'm
Thank
going to
you.
start with having Joe do that, and then we'll move on to the employee of the month.
Past health promotions and outreach events. On Wednesday, February 11th, Dr. Victoria Leapart, gynecologist, presented Mind, Body, Heart Health to employees of Boehringer Ingelheim. Located in Fremont, Boehringer Ingelheim is a manufacturer of biopharmaceutical products. 12 people attended. On Tuesday, February 17th, Dr. Stacy McDonald, obstetrician gynecologist, presented Women's Health, Minimally Invasive Gynecologic Surgery. 8 people attended. On Wednesday, February 18th, Washington Hospital participated in the Fremont Community Health and Wellness Resource Fair at Unitech College. Staff provided health education information on various health insurance programs and bone density screenings for osteoporosis. 14 people were screened for osteoporosis, and over 300 people attended the event. On Friday, February 20th, the Washington Hospital Sports Medicine Program provided athletic trainers and hosted a first aid booth at the Tri-City Area Special Olympics basketball tournament held at Newark Memorial High School. Over 290 student athletes participated at this event. On Monday, February 23rd, V. Nguyen, occupational therapist, presented Therapeutic Strategies for Parkinson's for the Parkinson's Support Group at the Fremont Senior Center. 35 people attended. On Thursday, March 5th, as part of the Diabetes Matters series, Chung Mei Shi, RN, presented Diabetes and Your Skin, How Uncontrolled Blood Sugar Affects Wound Healing. 12 people attended. Upcoming health promotions and community outreach events. On Tuesday, March 17th, from 1 to 3 p.m., Dr. Michael Parmley, internist, will be presenting Healthy at All Ages. On March 21st, from 10 a.m. to 1 p.m., Washington Hospital will host Stroke Awareness Day. This event screens community members for carotid artery blockage, atrial fibrillation, and provides cholesterol, blood sugar, and blood pressure screenings. This event is co-sponsored by Fremont Bank. On Thursday, April 2nd, from 7 to 8 p.m., as part of the Diabetes Matters series, Bing Bing Zhang, RN, will be presenting Gastroparesis, when diabetes leads to a lazy stomach. On Tuesday, April 7th, from 6 to 8 p.m., as part of the Stroke Education series, Dr. Ash Jain, cardiologist, Doug Van Houten, RN, and Luann Sudweste, RN, will be presenting Acute Management of Stroke, Chronic Care, and Stroke Rehabilitation. On Monday, April 27th, from 7 to 8:30 p.m., Dr. Victoria Leapart, gynecologist, will be presenting Restoring Balance, a 4-week stress reduction program. The Washington Hospital Healthcare Foundation Report. Washington Hospital Healthcare Foundation is proud to announce that it will host the 30th annual golf tournament at Castlewood Country Club on April 27, 2015. Held in memory of longtime Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. Tournament chair Lamar Hinton promises another enjoyable tournament. He says, "We had a great round of golf at Castlewood last year, so gather up some friends and enter a foursome. It's a great day out and it's for a great cause." To reserve your foursome, please call Washington Hospital Healthcare Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended the Unitech College Ribbon Cutting and Health Fair on February 18th. The Fremont Education Foundation's Excellence in Education Gala on February 27th, and ABODE Services' 9th Annual Journey Home Breakfast on March 5th. Washington Hospital Employee Association, W.H.E.A. In February, W.H.E.A conducted the annual Sock and Undie Drive to benefit those at both SAVE and ABODE Services. Along with W.H.E.A, individual hospital employees donated socks, undergarments, diapers, and personal care items to those in need. W.H.E.A is gearing up for the first Red Cross Blood Drive of the year. It will take place on Friday, March 13th from 12 p.m. to 6 p.m. in the Anderson Auditorium at Washington West. The event is open to the public. If interested in scheduling an appointment, please call 1-866-236-3276. The Washington Hospital Employees Association is currently accepting scholarship applications for the 2015 Don Pickenpaugh Memorial Scholarship. Don Pickenpaugh was the longest-serving board member on the Washington Township Healthcare District Board of Directors. During his 27-year tenure, he served as board president 5 times. This $2,000 scholarship is available for dependents of Washington Hospital employees. For more information, please contact Christy Caracappa at 510-494-7005. Washington on Wheels W.O.W Mobile Health Clinic. During the month of February, the Washington on Wheels Mobile Health Clinic, W.O.W, continued to serve community members at the Fremont Family Resource Center, the Fremont Senior Center, the Ruggieri Senior Center in Union City, as well as Briar Elementary School in Fremont. The total number of community members receiving health care at the Washington on Wheels Clinic during the month of February was 59. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was February's most viewed webpage with 16,524 views. InHealth, Channel 78. During the month of February, Washington Hospital's cable channel 78, InHealth, captured new programming, including a Diabetes Matters program, Diabetes and Stroke, What is the Connection?, and a health and wellness program titled Women's Health, Minimally Invasive Gynecologic Surgery. In addition, InHealth aired a health and wellness program titled Knee Pain and Replacement, Advances in Surgical Techniques, an enterovirus D68 public service announcement, the February Board of Directors meeting, and the Citizens Bond Oversight Committee meeting. Additional events. On Tuesday, February 24th, Washington Hospital held the groundbreaking ceremony for the Morris Hyman Critical Care Pavilion. More than 300 people turned out to celebrate the largest public works project in the history of the Washington Township Healthcare District. Named for the founder of Fremont Bank, the new building will house a new and expanded emergency department, a state-of-the-art intensive care unit, and an advanced coronary care unit. The new emergency department will be approximately 4 times the size of the current facility, which was built more than 50 years ago and intended to serve 16,000 patients a year. Currently, more than 50,000 patients visit the emergency room annually, second only to Highland Hospital in Oakland in terms of volume in Alameda County. The new building will have 3 floors, providing more space for new intensive care and critical care units. The pavilion will meet California's stringent and unfunded seismic safety mandate. It will be supported by a sophisticated base isolation structural system that will allow the building in an earthquake to move horizontally and/or allow for some vertical building displacement. The base isolation system is designed to allow the pavilion to continue to operate during and after an earthquake, essential for a hospital. In addition to a substantial donation from Fremont Bank Foundation and the Hyman family, other significant funding came from hospital employees who raised an aggregate contribution of nearly $1.2 million. Additional significant donations came from the Hospital Service League volunteers, medical staff, the foundation, and district board members. The community support must also be noted, as they overwhelmingly approved measures F, and Z in recent years. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070. And please follow us on Facebook and Twitter.
Employee of the Month. Go ahead and put it up. It's my pleasure to announce Cecilia Salinas. She's the March 2015 Employee of the Month, and she's a staffing clerk in the nurse staffing office. Cecilia first joined Washington Hospital in February of 2007. She's been an integral part of the nurse staffing office for the last 8 years as a staffing clerk. She has a vast knowledge of the staffing process and tries very hard to meet the needs of each unit. Cecilia is known for her compassion and commitment to the staffing office. A few of the things that her colleagues had said about her are, this is much well-deserved. Cecilia has been the center of the staffing office activity for many years and thoroughly knows her job. What sets her apart is her intensely personal approach to what she does. She knows all of the patient care services staff, and they are not just numbers to her. When someone has to call in sick, she expresses empathy. When there's a bereavement call, she has a supportive, genuine word to say. Another quote is, Cecilia tries very hard and is committed. She has good communication with the managers and is always kind to the nursing staff. She is an amazing coworker with a huge heart. She is always willing to help out whenever she is needed and always has a smile on her face. So Cecilia Salinas is the March 2015 Employee of the Month.
Thank you. We would like to introduce now Ed Fan for the construction report.
Thank you, President Danielson. So we have 2 parts of the report as usual, the parking garage. And there has been a fair amount of activity out in the parking area for the last month. And in particular, we've had drills on site, and we've started to drill the foundation for the garage. So that's, you can see here in this picture, some of the foundation or piers that have already been drilled, and it's a process of drilling open the hole and then shooting pressurized concrete down, and that will be the base upon which the first floor of the garage will sit. And as of this date, we're about 2/3 of the way through the process. And so one of the things that we had to do in this process is move into the BART, the area that's owned by BART. And that proved to be more exciting than we anticipated. We had to get a permit to enter and various other things on the BART property, so that was completed. And here you can see them basically removing curb and gutter that made parking spots over in the BART area, because the road that will now exit from BART and go down BART Way is going to be reformatted or built so that it can accommodate the punch-out that will occur from the garage going into what was formerly BART property. So you can see that they've had to remove curb, gutter, and sidewalk and then repave the area. Actually, it didn't have any sidewalk in it. It was curb and gutter. This, you can see, this is actually a part of the Washington Hospital fence line that has been pushed out into what was formerly BART property. So here you can see the former curb and gutter that was removed and repaved over for the new road. And then the fence is pushed out so that the garage can go out into what was formerly BART property. So that's what's happened here. We have a new fence line back facing BART. Pretty much the sidewalk along BART Way for residents walking to and from the BART station has stayed pretty much intact. There's a section that's been removed, but they can comfortably cut over on a crosswalk that's already there. We had to, with the permit to enter, we got behind a little bit, but they've been working hard to catch up, and so we're back pretty much on schedule, and we still anticipate a February of 2016 date of completion. As far as the Morris Hyman Critical Care Pavilion, I think we talked a little bit about this last month. This is pre-work to the actual pavilion work. This is one of the utility lines. This is for fire sprinkler that was put in place all the way down to the current emergency room driveway. So that's been put in place and then activated. So that is now along the entire perimeter of the construction site. And then the other thing that was done is we had a concrete slab that was up behind the ED modular building that had to be demolished for this will be the location of the future connecting corridor from the main hospital. So that has been removed. And the other noteworthy issue is the steel is already en route to the hospital to start the shoring for what we'll call the big dig for the basement and the sub-basement where the base isolation system will sit. And so we anticipate that steel being on site and started to be put in place in approximately 10 days. And so that work's already been all bid and finalized. This is basically showing you the final bidding process. We've already gone through 3 phases of bids and have 80% of the project price in, and this is the last section. So we anticipate having everything tied up at the end of April and getting contracts signed, et cetera, for the entire job just into May. So that's where we are. That is not impeding. We've already signed contracts to start the shoring project or part of the project. Any questions that I can answer? Yes, Pat?
Ed, would you refresh my memory for the garage? Where will the entrance be? Will it be on BART Way to get into the garage?
No, that's a good question, because we had gone through a variety of scenarios when we designed the garage, and the final scenario that was selected was an entryway within the Washington Hospital property. So you have to already be on the Washington Hospital property and drive to the back to get into the garage. Very similar to how employee parking was before. You had to come in, you could get there from 2 directions. When the garage is done, you'll only be able to get there from the front of the hospital or Maury Avenue because the road to Civic Center is going to be blocked with the Hyman Pavilion for the next couple of years. But a couple of years down the road, when the pavilion is completed, there should be 2 entryways to get to the garage. And the garage was envisioned to be parking for staff, volunteers, physicians, and have the front parking lots available for the public, and so that's what we anticipate.
Okay, thank you.
Mm-hmm.
Are there any other questions from the board? Okay.
Thank you.
Thank you, Ed. It's nice to hear the updates. Next on our agenda is our quality reports. Would you like to introduce?
Mary Beauron will again, our Senior Director of Quality and Resource Management, will make the presentation.
Thank you. Good evening. Tonight I wanted to go over our quality dashboard for quarter ending 12/14. To start off with, our core measure compliance. Related to patients who are coming in with heart failure, CMS requires us to evaluate their left ventricular systolic dysfunction, and we were able to do that with 100% of the patients from that quarter. And all of those patients also received the appropriate discharge instructions that enable them to have a better understanding of their heart failure status. Compliance for those were both above benchmark. Moving on to patients who are diagnosed with pneumonia, there's a very specific list of antibiotics that need to be used within the first 24 hours of the patients here. We were able to get 100% on that, above the national and state benchmarks on that. And for patients who have a heart attack, otherwise known as acute myocardial infarction, there's, if you're concentrating on the light blue aisle, there's a, with the patients who have aspirin at discharge, all these patients should be going home with aspirin. Of these patients, we did have 2 that did not make it home on aspirin on paper, but we went and checked back, and the patients were taking aspirin. It just wasn't actually documented on the medical record. So we've just made some improvements on how to make sure we do the documentation appropriately. And out of the 9 patients that came in this quarter that needed to get to the cath lab within 90 minutes to have a PCI procedure, 8 of them did make it within 90 minutes. We had 1 patient that did not. This patient came in, they presented with chest pain. They got an EKG within the first 6 minutes that they were here. We were able to get a physician in-house very quickly to do their PCI procedure. However, there were some anatomical structure things that related specifically to the patient, so that caused a little bit of a delay. So the patient did go over 90 minutes on that procedure, which is why you can see that fell below the benchmark and was at 89%. And then these patients also need to leave on a statin at discharge. We had 95% compliance with that. We did the same thing. Patient left with, we were able to catch the patient and get the statin ordered, but it was a little bit after discharge, so that fell out. As far as looking at patients with venous thromboembolism, this is basically how we prevent patients from developing blood clots while they're in the hospital. And the overall prevention, which means that we put on mechanical devices on their legs to help keep up their circulation, is above the benchmark at 94% compliant. And we also, CMS requires us to break it down further and look at patients in critical care to make sure we're preventing them from developing clots, because that's a higher risk population. We've done well with that, 97% compliant. And also, these patients are on blood thinners to decrease the risk of them developing clots. We've had good compliance there at 100%. With regard to patients who come in who have been diagnosed with a stroke, again, there's very specific medications that the patient needs to be on to prevent them from developing blood clots, with 100% compliance for that. And these patients require education. CMS is very specific, again, about making sure that they understand what happened with their stroke and that they understand how to follow up appropriately after discharge. So we've been able to get that documentation done well with the stroke team and stroke nurses for education at 100% compliance last quarter. And they also need to be assessed for what kind of rehabilitation they may need when they go home. And 98% of those patients were assessed appropriately and offered a form of rehabilitation. That puts us right about the benchmark on a national and state level. Surgical Care Improvement Project, otherwise known as SKIP, one of the older core measures that looks at making sure that patients have an antibiotic within the first hour of their incision and surgery. 100% compliant for that compared to state and national rates were above the benchmark. And again, we have to select a very specific antibiotic for this because we want to be really careful and make sure we're using our antibiotics carefully. Compliance was just about at the benchmark, just a little under 99%. And Also, we don't want to use these antibiotics for any longer than we have to, and so we have to make sure that they're DC'd within the first 24 hours after surgery, and so we were able to meet the benchmark on that at 98%. And again, we look at these patients to make sure that they are at decreased risk for developing clots. All of these patients were screened appropriately and had all of the mechanical interventions to prevent them from developing a VTE. Patients who have a bypass, a cardiac bypass, are required by CMS to be monitored after very closely with regard to their serum glucose. Basically, their blood sugar level is what they're looking at within the first 12 to 24 hours afterwards. We have really good compliance with that and 100%. We have a protocol that's followed closely in critical care to make sure that these patients are monitored appropriately. The other piece is that often patients, when they have surgery, ended up with a urinary catheter placed, and that's obviously a risk for infection, so you want to get that out as soon as possible so you can decrease that risk. And we have been doing well with that, having these patients have their catheter DC'd within 24 hours after surgery at 100% compliance. Again, those are above state and national benchmarks. We also look at patients who have surgery outside of the hospital that are not actually fully admitted to make sure that they are being given the right antibiotics and that the timing is done right. And we've been doing well with both of those, 100% above state and national benchmarks. Moving into our infection prevention indicators, we're looking at patients who have central lines to make sure that they do not develop a bloodstream infection while they're here. Again, consistently, we've been under the benchmark. So basically, that means we've had less than what the CDC would expect us to have. We did have 2 central line associated bloodstream infections last quarter. Those are really looked at by the critical care staff and med-surg staff and nursing. We look and try to find a root cause of what possibly led to those. But again, we're under the benchmark for those. And patients who develop surgical site infections, these are patients who come in, have a surgery here, and we monitor them to see if they've developed an infection within 30 days after their surgery. And we did have 6 of those last last quarter. 4 of them were deep and 2 of them were superficial. All of these do go to the surgery department, and they're all reviewed by surgeons to make sure that the standard of practice has been met. C. diff has been a challenge for us, as you know, especially in the last year. You can see that this is continuing to trend in a downward direction. Last quarter, we did have 10 hospital-associated C. diff infections, but again, that's almost half of what we had this time last year. Where this red arrow is showing is that when we implemented some Joint Commission recommendations on how to implement good hand hygiene at your hospital. That's where that arrow is. And when we started doing that and looking at changing our cleaning products, cleaning all the rooms every single day with Steriplex, we also looked and are very careful about what antibiotics we prescribe because that puts somebody at risk for developing C. diff. That whole combination seems to be working because it's coming down and will continue to stay like that. Just judging on some numbers I've seen even for January and February, we're still looking good with C. diff, so I'm happy to report that's coming down. Patients who come into the hospital and have to have a catheter placed are also at risk for developing a catheter-associated urinary tract infection, otherwise known as a CAUTI. We did only have 2 of those last quarter, keeping us below the benchmark there again. So again, that's less than what the CDC would expect for a hospital of this type and size. MRSA is a multi-drug resistant organism, very difficult to treat with antibiotics. We did not have any hospital-associated MRSA last quarter, which is excellent news. Puts us at 0. Same thing with VRE, multi-drug resistant organism, very difficult to treat with antibiotics. Did not have any patients acquire that last quarter here. Moving into our nursing sensitive indicators, these are indicators that reflect our nursing care. Looking at patients who develop pressure ulcers while they're here. This is all stages. We did not have any patients develop pressure ulcers last quarter, putting us below the CalMOC benchmark. And patients who fall this is monitored very closely. We did have 3 falls for last quarter. It's a little bit of a spike up. Every single one of these falls do end up going to the Falls Task Force. The nursing staff and everybody huddle as soon as there is a fall. This is reported. We sort of drill down and see if there's anything that we could do to prevent them. These patients are kept close to the nursing station. They're monitored closely. They're rounded on very frequently with CNAs. We put them on a bed that's very low to the ground. And so we are doing a lot of prevention around falls as a result of this number. The Joint Commission National Patient Safety Goals, again, these are things that Joint Commission has identified are high-risk areas that they want us to monitor very closely, such as how do you communicate with the staff at change of shift? You do a face-to-face communication to make sure that everybody understands exactly what's going on with the patient at change of shift. We monitor and do audits to make sure that's occurring, about 100% again for the last quarter. It's better than the goal of about 90%. Patient identification, making sure that we are checking to make sure that this is the right patient for the procedure or medication, 100% compliance for that also last quarter. And procedure timeout, so anytime the patient's about to have an invasive procedure, everything stops before that procedure and we check and make sure, is this the right patient? Are we doing it at the right time? Are we doing it on the right side? And it's sort of like a moment where everybody has to stop in motion and check and make sure that this is one last chance to make sure that we have the right patient procedure, 100% compliance for that, which is really good. Hand hygiene, I mentioned a little bit earlier that we implemented the recommendations from Joint Commission around hand hygiene. We've continued to sustain our hand hygiene rate. About somewhere in June last year, we were at 82.2%. It's continued to go up. You see 94.1%, and then last quarter, 96.5%. One of the hardest things to do when you implement a hand hygiene initiative is to sustain it. And so far, we've been doing well on that, and the patient safety team has really been monitoring and making sure that we're keeping this as a focused initiative for the hospital. And readmission rates, CMS has benchmarks and expectations around patients that should be managed well outside of a patient, outside of an acute care setting. So we're closely monitor that if we discharge a patient and they come back within 30 days, why? And as far as patients with pneumonia, you can see that the last 3 months for quarter ending 12/14, we were at 12.9%. That's better than the CMS national rate, which is, they expect you to see about 17.3% of those patients back on slide 12, so that's good for pneumonia. Patients who are in heart failure, otherwise known as CHF, same thing there. We have had, it's varied for the last quarter from about 9 to 27%, but overall our 30-day readmission rate for heart failure is 22.5. This puts us just slightly below the national benchmark for CHF patients at about 22.7%. And looking at patients who've had an AMI, same thing. Last quarter, we were at 17.7% of our AMI discharges were readmitted within 30 days. This puts us, it's just slightly better than the CMS national rate of 17.8. So we're right about there, basically, for the benchmark, seeing about as many as CMS would expect. That's it. Thank you. Any questions?
Questions?
Thank you.
Thank you. Good report. It's always nice to hear good information. Finance report.
Good evening.
Good evening.
Tonight we'll look at the operational and financial results for Washington Hospital for the month of January 2015. And January was a pretty good month for the hospital. Starting with our operating indicators, the average daily census for the month was 1.6 above budget at 183.5. January saw 1,178 admissions against the budget of 1,183, pretty close. Patient days were within 52 of budget at 5,690. We had expected 5,638. Outpatient observation equivalent days for January were 37 above budget at 263. Our average length of stay based on discharges for the month came in pretty close to budget at 4.92. We'd expected 4.77. Moving into operating indicators, case mix index for the month was lower than budget at 1.44. We had 147 deliveries in January, 5 above the budget. Surgical cases were almost right on budget at 356. That included our joint replacement cases that were 3 below budget at 117. Neurosurgical cases were 5 below budget at 23. And our cardiac surgical cases were 1 above budget at 12. Cath lab procedures for the month were 16 above the budget at 622. In January, we had 7,687 outpatient visits, about 543 below the budget. In the emergency room, I think as we mentioned last month, saw the highest volume that we could find in the records at 5,164 visits, 422 above the budget. So all the staff in the hospital was really cranking in January. It was a very busy month. Quick look at our cath lab activity for January. Peripheral vascular procedures again pretty much dominated most of the activity at 45%, followed by cardiac, and then filled in with the other types of procedures that are going on in there. Looking at productivity, with all this activity we had in the month, we did pretty well on our FTEs. Productive FTEs for the month came in almost 131 below budget at 1,108. We had 225.5 non-productive FTEs, giving us total FTEs for January at 82.1 below the budget, 1,333.5. I think a lot of that is reflective of the level of activity we had and the fact that we had been running with lower staff, and really we're trying to flex up to that volume. But again, folks worked awful hard in the month and got it done. Our FTEs per adjusted occupied bed for the month at 5.47. We'd expected 5.94. So again, staffing was a little bit below the level of activity that we were seeing. Now we'll move into the financials. Total patient revenue for the month came in within 1% of budget at $183,119,000. Our contractuals for the month were above budget at 78.44%. And as we've talked about in the last several months, we're really seeing that shift from private up to Medi-Cal with the Medi-Cal expansion. And when I took a look at this today, in fact, when you look at the reserve for bad debt combined with our contractuals, we're really right on budget. So it's really a shift there. So we ended the month with net operating revenue about $3.3 million below budget at $39,757,000. Our operating expenses for the month came in $3.8 million below budget at $37,722,000. And again, the biggest driver there was about a $2.6 million variance in bad debt, which shifted up. So we end the month with a healthy bottom line at a little bit over $2 million. We'd expected almost $1.5 million. Non-operating income for the month came in at almost $1.8 million. That includes a $722,000 unrealized gain in our investments. So we end the month with a total bottom line 48.4% above the budget at $3.828 million. This was our Governmental Accounting Standards Board look at this, which is how we do our audited financials. Quickly run through the Financial Accounting Standards Board presentation, which is how the financial markets would tend to look at us. Operating bottom line doesn't change at a little over $2 million. We pull out our property tax revenue that services our general obligation debt and our unrealized gain on our investments to come up with a total bottom line from a FASB perspective. Still a healthy $2.3 million, about $525,000 above the budget. So are there any questions on January's results? Pretty good month.
Good month.
Yeah.
Very good, very good. Kimberly, would you give us the hospital operations report, please?
Yes, I will continue with February. In many areas, February also was a good month. The month of February saw 987 patient admissions that resulted in 5,078 patient days of care. This is 34 lower than the budget of 1,021 admissions and 3.9% above the budgeted patient days of 4,889. Average daily census for the month was 175. The average daily census recorded in February of last year was 172. February's high and low census was 209 and 142 respectively. Outpatient observation equivalent days of 259 were higher than the budget of 189 by 70 and higher than February 2014 by 36. Based on discharges, the average length of stay for adults and children in February was higher than budgeted at 5.09. This is slightly higher than January's average length of stay of 4.92. The budget anticipated an average length of stay of 4.79. The birthing center saw 139 deliveries in February compared to the budget of 137. February's deliveries resulted in 270 baby days. Newborns totaled 140 in the month. For comparison, there were 141 deliveries in the hospital in February of 2014. For the month of February, there were 308 surgical cases, 18 or 5.5% below the budget of 326. This includes cardiac surgical cases that were 5 or 55.6% above budget, neurosurgical cases that were 10 or 37% below budget, and joint replacement cases that were 1 above budget. General surgery cases were below budget by 14. There were 611 cases were seen at the outpatient surgery center versus a budgeted of 543. For the month of February, total procedures in the cath lab were 571 versus a budget of 553. For comparison, overall cath lab volume for February of 2014 was 548 procedures. Overall, inpatient cath lab procedures were 24 or 8.6% less than anticipated, and outpatient procedures were 42 or 15.3% more than expected. In terms of non-emergency outpatient visits, our outpatient visits for February totaling 7,061 were 99 or 1.4% lower than the budget of 7,160 and lower than February 2014 of 7,476. Emergency room and clinics. The emergency room recorded a total of 4,407 patients, a daily average of 157. This was 188 or 4.5% above the budget of 4,219 and 228 above February 2014 visits of 4,179. Higher than budget, but not quite as high as what we saw in January. The Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,410 patients during February, 93 or 2.7% less than the budget of 3,503. Total system emergency room and clinic visits for February were 7,817 compared to a budget of 7,722. Full-time equivalents for the month of February totaled 1,347, including 13 agency personnel. This was 29.3 lower than the budget of 1,376. Productive FTEs were below budget by 36.2 for the month. Non-productive FTEs came in at 6.9 FTEs above budget. Productive FTEs for AOB were 4.88 in February, below the budget of 5.36. Total FTEs per adjusted occupied bed were 5.52, which is below the budget, again, of 6.01. Patient mix. Preliminary information indicates that inpatient revenue for the month of February amounted to approximately $120.5 million, compared to the budgeted estimate of $125.1 million. Of this amount, 56.5% was Medicare, including Medicare HMO, and 16.8% was Medi-Cal, including Medi-Cal HMO. This compares with the budgeted inpatient revenue percentages of 57.9% Medicare-sponsored patients and 17% Medi-Cal sponsored patients. Total government program revenue for February was 73.3% of total inpatient revenue versus the budget of 74.9%. So in summary, In February, there were 34, or 3.3% fewer admissions and 189, 3.9% more inpatient days than anticipated in the budget. Surgical cases were below budget by 18, or 5.5%, and cath lab procedures were above budget by 18, 3.3% for the month of February. Outpatient visits for February were 99, 1.4% below budget, and ER visits were 188, 4.5% higher than anticipated. Clinic visits for the month were below budget by 93, or 2.7%. Total paid FTEs were below budget by 29.3, 2.1% for the month, and above the last 12 months average of 1,327.7 by 19.3 FTEs. FTEs per AOB were below budget. Inpatient charges for the month were below budget by approximately $4.6 million, 3.7%. Outpatient charges were higher than the budget by approximately 2.9%, or $2.9 million, or 7.4%. So total hospital charges for February below budget by approximately $1.7 million, which is about 1.1%, so pretty much right on target. On February 28th, there were 178 days of cash on hand, up from 173 last month, and then looking at the same period last year, we were at 153. So have come up significantly in terms of days cash on hand. The total days revenue in accounts receivable at February 28th was 63.46. The days revenue in accounts receivable excluding Medi-Cal was 63. Days in accounts receivable excluding Alameda Alliance was 60.29. During the month of February, we had approximately $762,000 of charges which were approved or pending for charity care assistance. And again, it goes to Chris's comment about we're seeing the impact of more of the Medi-Cal expansion and more going into Medi-Cal. Are there any questions on the operations report for February?
Thank you, Kimberly.
All right, thank you.
We now have several action items on the agenda. Consider the A. Director Eaton.
Madam President, in accordance with the district law policies and procedures, I move for the approval of the Medical Executive Committee proposed Allied Health Manual.
Second.
We have a motion and a second. Could we explain what the Allied Health Manual is?
Yeah,
please?
Dr. Lenny is going
Dr.
to.
Lenny,
It's a
are you
medical
ready?
staff.
So just like the construction of the new emergency department and critical care unit brings the hospital into modern times as far as patient care goes, this is a document that's a long time coming for the medical staff and acknowledges the expanded role of allied health professionals in the care of our patients, and delineates and defines the scope of practice for these professionals. We currently have 3 categories of allied health professional now: the physician assistant, nurse midwives, and registered nurses that assist during surgery. And this manual adds an additional category, the nurse practitioner, to our cohort of allied health professionals as well.
Okay, thank you. Any questions from anyone? No? Would you take roll, please?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eapen?
Aye.
Thank you, motion passes. Our second motion,
Madam President, in accordance with the district law policies and procedures, I move for the approval of the Medical Executive Committee proposed nurse practitioner medicine privilege form.
Second.
I have a motion and a second. Dr. Lenny, would you do this, the honors of that?
Okay. And so this kind of dovetails with our allied health professionals manual. This delineates the actual privileges for the nurse practitioners.
Okay, thank you. Any further questions, discussion? Christine?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eapen?
Aye.
Thank you, motion passes. There being no closed session this evening and no further business, this meeting is adjourned.